Good afternoon again. We're going to move on to another tumor type. So my second talk for this afternoon is on malignant pleural mesothelioma. And I'll tell you a little bit about how big a problem it is and about the surgical management of it. So what is malignant pleural mesothelioma? It is a primary tumor of the pleura. It is considered to be rare, but it's actually more common than mesothelioma in the abdomen, which also occurs. The majority of cases, certainly in the UK, are linked with past asbestos contact, and about 85% of all mesotheliomas in men are attributable to occupational exposure. So the use of products containing asbestos was therefore banned in the UK only in 1999. You would have thought that this would have occurred a lot earlier, but in fact it was only over 20 years ago. What we also know about mesothelioma and past asbestos contact is that there's a long latency from contact of asbestos to presentation with the disease. The incidence worldwide is increasing. There is, however, a lack of data from a large part of world population. And there was a paper published in 2017 where they tried to estimate from WHO mortality database what the annual death worldwide would be. And they thought it was, they came to a figure of around 38,400, which some say is probably an underestimate. This is the crude mortality rate for the various countries they looked at. Great Britain is up here because we do have a lot of cases. Egypt down here. This is a map of the world where asbestos has been banned in green. And there are only 67 countries that have banned asbestos. It is not banned in China, India, Russia, or indeed the United States. In the United States, it's partially banned or regulated. There's some places where it's regulated, but it's still produced. And then there are some places where asbestos is actually banned, but the ban is not enforced. So it's still probably going to be a problem for us thinking about the latency period before mesothelioma develops. We do have quite robust data on mesothelioma deaths in the UK, dating back to probably the 1960s, but this is a curve of the annual deaths that occur in the UK since the 1980s. And you can see it's gone up in the dark blue line. This is where there has been industrial disability benefits paid out. There are currently approximately 2,500 cases annually, and that has been the case since 2013. And it's thought that it's likely to fall after 2020. But remember, the latency period is 40 years, and asbestos was only banned in 1999. So I'm not really certain that we're really going to see the fall that quickly. More than half of the annual deaths are now in patients aged over 75. And more cases of men than women present with mesothelioma. It is likely related to occupational history. So the predicted lifetime risk for men born in the 1940s who did more than 10 years of work in these occupations, carpenters, plumbers, electricians, painters, this is their lifetime risk of developing mesothelioma. There's also patients who have a non-occupational exposure. Some people call it para-occupational. So if you've got a relative or partner who works with asbestos and comes home in their overalls, which is covered in asbestos, your partner may become exposed to asbestos indirectly. Or they may be living in the vicinity of asbestos factory, or there might be environment exposure that may account for the development of mesothelioma in some patients. We do have a national mesothelioma audit in this country. This was published only last year. The audit was done for Northern Ireland, England, Wales, and Guernsey. And this particular audit published data over a 3-year period, 2016 to the end of 2018, where they found 6,950 pleural mesothelioma cases, fewer peritoneal mesothelioma cases. The median age was 76. There were over 80% men, and only 48% received some form of active anti-cancer treatment, either in the form of chemotherapy, some form of resection type surgery, 5%, and 14.8% received radiotherapy. As you can see, the survival is poor, 1 year, 40%, and 3 years down to 10%. I tried to look for some epidemiological data from Egypt, and this was the only paper I found, which was published in 2010, and it looked at data over a 10-year period in 2 centers. The incidence is much lower, according to this paper, than in the UK. So over 10 years, you have 584 patients. And the author said that they thought that there was a peak around the 2004-2005 period, and seems to be a drop-off since then. What was also interesting is that over 80% of the patients did not have an occupational or exposure history of asbestos. And what was also interesting was that the male to female ratio was fairly evenly distributed, so 1 to 1. The median age for these patients was 40, as opposed to a much older age group in the United Kingdom. So, how do patients present? Well, the common presentations are with breathlessness and chest pain, because patients tend to develop a pleural effusion. And if they've got pleural disease impinging on intercostal neurovascular bundle, they can develop pain. Less commonly, you might find that the patient has got a history of weight loss, fatigue, fever, and cough. If you delve a little bit deeper, you might find that there is an occupational history, including para-exposure. And if you examine the patient who may have a pleural effusion, you will have the signs of very often a unilateral pleural effusion, slightly more likely on the right than the left. So these symptoms and these findings on examination should prompt you to do a chest X-ray. There are other imaging modalities which are useful. So if you find a patient with a pleural effusion, you may want to do an ultrasound to aspirate or drain the pleural effusion. But there are some findings that the ultrasound can also give you. It can show some diagnostic features of pleural thickening if it's greater than 1 centimeter. And it can also demonstrate nodular pleural thickening, which we do see in mesothelioma. CT scan, however, is the mainstay of imaging for malignant pleural mesothelioma. And some of the key findings where you might say, okay, this looks much more like mesothelioma than other malignancies, when you find mediastinal pleural thickening or thickening in the interlobar fissures. PET scan is sometimes performed. And the occasions when I might use PET scan as a diagnostic tool is when you want to look for a site of biopsy in the pleura. So you look for the most avid area to guide your biopsy. However, if you've done a pleurodesis because your patient has had a history of recurrent pleural effusion, TELT pleurodesis will cause all the pleura to light up. So it's particularly unhelpful to perform a PET-CT in this sort of setting, or indeed if you've got some inflammatory pleural disease. So although imaging might point you towards the possibility of mesothelioma, you do need to make a pathological diagnosis. I put aspiration of pleural fluid in brackets because from a pathological perspective, mesothelioma diagnosis should be made on histology, not cytology. However, you may still want to be considering aspiration of the pleural effusion because you might want to be looking for other forms of malignancy like lung cancer. So how do we obtain a histology? Well, there are different methods, some less invasive than others. and some less effective at giving you a diagnosis than other. Going from top to bottom, here we've got a blind closed needle biopsy done with an Abrams needle. And as that suggests, it is done blindly, so you don't actually have a target spot, but you usually enter from the posterior region, targeting pleural, hopefully thickened pleura in the costophrenic recess. The sensitivity of this procedure ranges between 27 to 60%. This improves if you add image guidance to it, either in the form of ultrasound or CT scan, and your sensitivity goes up to 87%. Direct vision of the pleura probably will increase your sensitivity further. So you can either do a medical thoracoscopy. In this country, it's normally done by respiratory physicians, or VATS thoracoscopy, which is done by surgeons. And I think the surgical biopsy is improved further with a sensitivity of 95%, probably because you can take much larger biopsies for the pathologist to assess. If you have an obliterated pleural space, so no pleural effusion, and the pleural lining stuck together, then you may consider performing a small thoracoscopy. About 4 centimeters is usually sufficient, and taking a full thickness pleural biopsy with or without a resection of the overlying rib, depending on how crowded your rib space is. Pathology is important because it does give us an idea of prognosis. WHO published a classification in 2015-16 for pleural tumors, which is pretty extensive, and I haven't put it in here, but this is a table from the BTS showing the 3 mesothelioma subtypes which we tend to work from. The epithelioid, which is probably the most common and has the best prognosis, and on the other end, the sarcomatoid, which is less common but has got the worst prognosis. In between, we call it biphasic, so that it usually has a combination of epithelioid and sarcomatoid subtypes. And as you can imagine, the prognosis is sort of in the intermediate region. You've already heard earlier on that staging is important for lung cancer, and similarly, it has got prognostic information for mesothelioma. This is the latest edition of mesothelioma staging, published in 2016 by the IASLC, and it looked at revising previous editions of staging, of which there have been many over the past 40 years, mostly put together by surgeons. This has been probably simplified, I would have said. And if you look at the T stage, for example, in the previous edition, there was a T1A and a T1B, where they differentiated whether it was visceral or pleural involvement, which you can't really tell on a CT scan. So that has now been amalgamated to T1, where the tumor involves the ipsilateral, parietal, or visceral pleura only. With T2, it involves the ipsilateral pleura, but with invasion of the lung or the diaphragmatic muscle. T3, there is invasion of the endothoracic fascia, the chest wall, solitary, the mediastinal fat, or transmural invasion of the pericardium. Now, this has really been written to say that, yes, this disease probably is still resectable, but when you get to T4, where it involves the ipsilateral pleura with diffuse multifocal invasion of chest wall, or it invades the contralateral pleura, the peritoneum, mediastinal organ, spine, this is pretty much unresectable. They've also revised the nodal classification. There's N0, N1, and N2. And then the previous staging versions, there was an N3, following the same sort of classification as lung cancer. However, we do know that the spread of mesothelioma through the lymph nodes doesn't seem to follow the same pathway as lung cancer. So N0 obviously means that there is no lymph node involvement. N1 means that it is ipsilateral intrathoracic lymph nodes, and that means hilar or mediastinal. So subcranial, paratracheal, aortic, aortopulmonary, periesophageal, peridiaphragmatic. So all where the previous ipsilateral N2s, they now become N1. And N2 would be metastasis to contralateral intrathoracic lymph nodes, so contralateral mediastinal, contralateral hilar, and also to the supraclavicular lymph nodes. These are the definitions that you can find. Distant metastasis is still classified as M0 or M1, and distant metastasis usually occurs quite late on in the disease process. I have already alluded to that staging is important because it predicts our prognosis for the patient. And going through from stage 1A to stage 4, you can see that the prognosis is poor. So we talked about the imaging for diagnosis, but there are also imaging and other procedures that you may want to be considering for staging the patient, particularly if you're thinking about some form of active cancer treatment. Now, the majority of patients will present quite late on because by the time they have symptoms, a lot of patients have already got advanced stage cancers. So the majority of patients probably will not have any active cancer treatment. And you can see that 48% of patients in the National Mesothelioma Audit in the UK, only 48% had any form of anti-cancer treatment. So with staging, well, you would have already done a CT scan to help you make the diagnosis, but the CT also shows that if you do a tumor volume calculation, it does seem to correlate well with the PT end stages and overall survival. PET-CT, if you've not done it for staging, you may be, if you've not done it in the diagnostic process, you may consider it if you're planning on putting your patient through treatment, particularly surgical treatment, to try and detect distant metastasis. And that's quite a reasonable test for detecting distant metastasis, but it's less effective when you're looking at nodal disease because the mediastinal pleura and a lot of the lymph nodes are located quite close together. And beware once again of TELT pleurodesis. The SUV max number, which you get from performing PET-CTs, may have some prognostic significance as well. MRI scan is not routinely done, but if you were assessing a patient's resectability, it might be useful at the margins of disease, for example, at the apex around subclavian vessels, whether this is resectable or not. It is better than CT at detecting invasion through the diaphragm and also for T3 disease, but it has limitations for nodal staging. So what do we do for nodal staging then? Well, you could consider mediastinoscopy or EBUS. This is a suggested approach by the European guidelines published last year. So chest X-ray for a patient you suspect with mesothelioma. You might consider basic staging for patients fit for treatment with a CT, chest and abdomen. And for those you are considering surgical and chemotherapy treatment, consider a PET scan, stage the mediastinum with EBUS initially, and if it doesn't give you an adequate result, consider mediastinoscopy. There are also MRI for defining whether a tumor is resectable, and some clinicians go as far as offering patients laparoscopy and contralateral VATS to exclude disease that you don't see on the CT scan in these other cavities before proceeding with radical surgery. So what is our role then in the management of malignant pleural mesothelioma? Well, we've already talked about thoracoscopy for diagnosis, so VATS biopsy. We can also have a role in staging where we do mediastinoscopy or VATS assessment, whether it's ipsilateral or contralateral. Some surgeons do EBUS, not only physicians. The surgical role in laparoscopy. And We can also be involved in treatment with surgical resection, and there are two operations that we'll discuss: extraoral pleural pneumonectomy (EPP) or extended pleurectomy decortication (EPD. And the final thing that we're involved with, probably more than anything else, is palliation, because, as I said earlier on, a lot of patients are symptomatic with the disease and they present too late for active treatment. So this may be in the form of pleurectomy decortication done open or VATS. And people say it's only partial pleurectomy that can be achieved at VATS. TELPRU drudge for pleurodesis, or an intrapleural catheter placement for patients with trapped lung. So early pleurodesis, if you can do it, is key for symptom control and prevention of trapped lung. But what is the evidence then for which operation we should be doing? Is there any data out there to help us? Well, there are two surgical RCTs in mesothelioma that have been performed, and this is one of them, called the MESO-VATS trial, which was published in 2014, looking at the palliative procedures for patients presenting with mesothelioma with pleural effusion. It was really put together because there was reports that debulking surgery for mesothelioma is possible via VATS, which could lead to a symptomatic improvement and possible survival benefit. So the trial was done in the UK in 12 centers. In one arm, after randomization, the patients would undergo VATS, partial pleurectomy, to remove the pleura in order to help the lung expand to try and achieve pleurodesis, or in the other arm where TELP pleurodesis was performed. It took them 9 years to recruit. Remember I said that surgical trials are incredibly difficult to perform. But the other factor was, I think, initially there was only one center trying to recruit into this study before they opened up to the 12 centers. In the end, they randomized 177 patients, 88 to TELP pleurodesis and 87 to VATS partial pleurectomy. And what they found was that there was no difference in the overall survival at 1 year. VATS partial pleurectomy did improve the control of pleural effusion in the first 6 months after surgery, and also did improve quality of life after 12 months. But there was quite a lot of more surgical complications associated with VATS partial pleurectomy. So on the basis of this, particularly with no difference in the overall survival and the high surgical complication rate, I think most people will try and do a VATS TELP pleurodesis over a partial pleurectomy. What about treatment in mesothelioma? Surgical resection? Well, the problem with mesothelioma is that there's no anatomically defined organ boundaries. So, for example, like with lung cancer, you've got a cancer within the lung, you take out the organ. In mesothelioma, the traditional principles of oncological surgery is pretty much impossible. So this was an operation that some surgeons thought was the only way to remove the pleural tumor, and it is now called extrapleural pneumonectomy, but when it was first performed in 1949 by a surgeon in Newcastle, it was called pleural pneumonectomy. And this involved the en bloc resection of the parietal pleura, the pericardium, the diaphragm, the lung, and of course the visceral pleura. So all of this with patch reconstruction of the diaphragm and the pericardium. In 1976, a series of 29 patients was reported by Eric Butchart from, at that time he was still working in Newcastle, and he compared this in a non-controlled way to 17 non-surgical patients. In this group of patients, there were 9 hospital mortalities, so a 31% mortality rate. For the patients who survived, there were 4 patients who had major morbidity and a total complication rate of 44.8%. So remember, this was done in the 1970s. 3 patients survived 2 years or longer, and he found that they were epithelial, or what we now call epithelial tumors. And in this non-surgical patient group where he did he states in his report he didn't have full medical information. He did find 3 patients with epithelial tumors surviving 3 years or longer. However, in spite of this, he still proposed that this operation in selected group of patients was something to be considered. And the reason was that many of the patients who died could have an avoidable death if the operation was done a little bit better. He was quite frank about it. And also if the post-operative care was better. So he came up with this selection scheme. He would only operate on patients who were under 60, who were fit, who had stage 1 mesothelioma, and who had epithelioid or epithelial tumor types. So this operation has actually gone on since the 1970s, performed by many surgeons around the world. The most prolific of all is the late David Sugar Baker, who has probably the biggest case series. And this is one of his last publications in 2014, where he looked at extrapleural pneumonectomy in the epithelioid subgroup. Remember that Burchardt's in-hospital mortality was 30%. The in-hospital mortality for this group is 5%, and he reports a median overall survival of 18 months, with 1 year survival 67%, but by 3 years it was down to 28%, and by 10 years, 4%. He also looked at the nodal status, and if you had no lymph node involvement, obviously you have a better prognosis, 26-month survival, versus N3 disease, where there was a 7-month survival. So this is the second surgical study that I mentioned earlier on. This looked at extrapleural pneumonectomy, and it's the only randomized controlled trial of extrapleural pneumonectomy and mesothelioma. It was done as a feasibility study in the UK in 12 centers, and all patients underwent induction chemotherapy. They were then reassessed. As long as they did not progress, they were randomized to either EPP followed by post-operative hemithoracic radiotherapy, or the non-surgical arm where no EPP was performed. The objectives, because it was a feasibility study, was to assess whether it was feasible to randomize 50 patients in 1 year, the proportion randomized who received treatment, the proportion eligible who proceeded to randomization, what the perioperative mortality is, and there was also quality of life data. It took them, I think, 3 years to randomize 50 patients, 24 into EPP group and 26 into no EPP group. But you can see that not all the patients complete the treatment in which they were allocated to. Only 16 patients had EPP. 5 patients didn't have it because some of them decided they didn't want it. In 3 patients, the operation was started, but it was felt to be not resectable, so abandoned. And of the surgical patients, 2 died within 30 days, and a further patient died in hospital. There were 10 adverse events in the EPP group compared to 2 adverse events in the no EPP group. The median survival was also longer, 19.5 months in the no EPP group, whereas it was 14.4 in the EPP group. But this was not felt to be significant. In the no EPP group, 6 patients also decided that they didn't want to be in the no EPP group and received the surgery off trial, with 1 patient dying perioperatively. So when we looked at the quality of life analysis, there was also no difference. The authors concluded that in view of the high morbidity associated with EPP, and also in other non-randomized studies which were being published at the same time, the feasibility study did not proceed to a larger study. Although the data is limited, it was felt that radical surgery in the form of EPP within trimodality therapy offers no benefit and possibly harms patients. As you can imagine, there was a lot of criticism about the study, particularly being underpowered, and also the crossover in the allocated groups. And many surgeons did not feel that they could rely on the data from this small study to guide further treatment in terms of EPP. So is there really a role for surgical resection in mesothelioma then? Well, some proponents of EPP, for example, in this systematic review, have stated that median survival is improved with it. It goes up to 27 months in some studies. The perioperative mortality ranges from 0 to 11.8%, but all these studies included in the systematic review were all observational studies, so likely to be highly selected patients. There was also a meta-analysis published after the MARS trial was reported in 2015, looking at pleurectomy decortication versus EPP. And they found 1,500 pleurectomy decortication patients and almost 1,400 EPP patients. And they also reported there was a significantly higher proportion of short-term deaths in the EPP group compared to the pleurectomy decortication patients, but there was no difference in 2-year mortality. However, as you can imagine, again, with observational studies, there was significant heterogeneity. So the question now is, okay, if EPP is not to be offered to patients because of morbidity and mortality, is pleurectomy decortication a better operation, as particularly it would be preserving lung function. So you would only be removing the parietal visceral pleura and leaving the lung behind. So if lung function is preserved, will quality of life be preserved? There's fortunately a trial called the MARS-2 study, which has been recruiting and has actually completed recruiting last September. And it looked at the extended pleurectomy decortication versus chemotherapy. Extended pleurectomy decortication with chemotherapy versus chemotherapy alone. The primary outcome obviously is overall survival, secondary outcomes, quality of life, progression-free survival, adverse events, and cost effectiveness. A pilot study was similarly done, and they recruited within 2 years, and the full trial recruiting 328 participants completed last September, a little bit later than scheduled due to the COVID pandemic. Hopefully we should have results from the study within the next couple of years. I can't mention mesothelioma without mentioning systemic anti-cancer treatment and radiotherapy, because I believe that on its own, surgical resection is probably insufficient. So other effective treatments in terms of chemotherapy for mesothelioma, well, platinum and pemetrexate has currently been shown to have a survival advantage for patients receiving it, and it's regarded as first-line treatment. There's also data showing that Avastin also significantly prolongs survival when you add it to the pemetrexate. In terms of radiotherapy, there have been several RCTs assessing prophylactic radiotherapy to drain and track sites, and 2 recent phase 3 studies in the UK actually showed no benefit, so this is not now routinely offered in the UK. Radiotherapy may have a role for pain relief caused by tumor infiltration into adjacent structures, but the question regarding radiotherapy post-surgical resection has yet to be fully answered. So in summary, the incidence worldwide for mesothelioma is likely to continue to rise. It still has a poor prognosis at the moment. There is some importance with early diagnosis and managing symptoms. There is an importance of staging as well as assessing fitness of patients in order to consider the form of treatment that they would be getting. And also, there is an importance of balancing life expectancy with quality of life. Because mesothelioma is still regarded as reasonably rare, specialist mesothelioma MDTs may benefit patients so that clinicians who have a special interest in treating this disease can be involved. And I think we still need a lot more clinical trials to guide us for the future. Thank you.